Thank you again for joining us today. This webinar is being recorded. Just a few quick housekeeping items. Webinar is being recorded, so this recording will be available to you in the next 24 hours. All of you are muted by default to reduce any background noise. Please utilize the question and answer tool in the sidebar and upvote any questions submitted by others so that we can ensure that we address all of your questions effectively during the course of our conversation today. With that, I am Jody Patton. I'm our VP of Growth here at OneUp Health, where I focus on building all of the collaborations with our customers that advance our mission to transform healthcare through technology. Also joining me today are Mohammed Juni, Chief Product and Technology Officer at OneUp Health, responsible for developing the company's product strategy and leading engineering and product management, and Elisa Heyman, Principal Product Manager at OneUp, specializing in designing intuitive user experiences that simplify these complex workflows and systems within our healthcare ecosystem. To frame our topic today, we really are focused as we think about the next generation of where OneUp heads. We've spent a lot of time with our customers working on compliance and all the solutions that CMS has put forward. But as we look to the future, we know that clinical data and NCQA reporting really become critical infrastructure issues that we can address. So as we move from as we think about where NCQA is headed and where they've been and where they're headed, they're moving from sample-based reporting towards this really full population, FHIR-based digital measurement. Health plans, and as health plans move forward, they have to rethink about how you're acquiring that clinical data, how it's validated, and how it's actually activated across the enterprise. This is not simply just a reporting challenge anymore. It's a fundamental shift in healthcare operations. How we're going to structure this webinar today is really conversational. Elisa and Mohammed are going to answer key topics around this conversation and really lead us into what the next generation of healthcare is beginning to look like. With that, I'm going to start with our first question. Elisa, let's start at the foundation. For folks who live in the ECQM world today, what exactly is a digital quality measure, and how is DQM different from ECQM in practice, just not in name?
Yeah, absolutely. First, hi, everyone. Nice to meet you virtually. Digital quality measures are a super exciting advancement, I'd say, for quality measurement. There's a number of differences between digital quality measures and current state or ECQMs. First of all, currently, you'll see like on an annual basis, a spec will get released. That's like dozens of pages of narrative that needs to get translated by teams and turned into like actual calculation. You know, often there's a handoff to IT teams where they kind of determine the calculations based off of this narrative that's provided. That's kind of a first challenge that exists with current state, in that there's that interpretation layer that exists. So in theory, you could have two identical payer organizations, identical members, but they could compute different measure results rather. Both could defend that logic, but one or both of them could actually be incorrect because there's that translation layer of like narrative to actual calculations. So one of the first really exciting things about digital quality measures is the specs are released in like executable code. So that translation layer is gone, which ensures consistency and hopefully streamlines the process for everyone involved. Another great thing about digital quality measures, they're built on FHIR, kind of the interoperability language. They're designed to build off of data that's pulled from a variety of sources. ECQMs, those are primarily focused on pulling in data from EHRs. Digital quality measures are focused on pulling on data from a variety of sources. So I'd say like ECQMs kind of fall under the umbrella of DQMs, but the fact that DQMs are intended to pull from FHIR resources from a variety of sources, that'll really help reduce the manual chart chase, having to try and find records on members. And instead, you'll be able to directly get FHIR data from a variety of sources and use that data to calculate your measures. So it should be a really exciting, streamlined experience.
I love to hear that. I think it's a really exciting movement into the future. Let's continue on that talking point. It's been said that missing or messy clinical data is really a multi-million-dollar problem. Can you talk a little bit more about that? What are you hearing from the experts in the industry and who you've been talking to?
Yeah. Yeah, I've had the opportunity, and a number of us at One Up Health have, to speak with payers both within and outside of the One Up customer base, just really learn from the industry as a whole. And messy clinical data and, measures, how they're working now, are definitely a $1 million problem. First of all, for like MA plans, if your measures are impacting your star ratings and you're going from a 4 to a 3.5, that could be like a 50 to $70 million impact right there. So obviously that's huge, and everyone wants to avoid that. But in talking with payers, I mean, most everyone has had experiences of single measures missing, causing millions of dollars of impact. One payer we talked to, there was a depression screening, like messy data problem that led to a $2 million impact. Another payer we spoke with, there was a postpartum measure that they missed, and it was all due to just abstractors kind of fumbling on the date input, which is really important for postpartum measures. And so that led to a $7 million hit just because of some missing dates. And so it's a very expensive problem if you're missing measures, and it's not uncommon to have this type of an impact. And then it just, everyone we talk to, they're spending a lot of money on trying to get it right. One payer we talked to described like a small army of people, trying to acquire clinical data and make sure it is clean and accurate. Others have seasonal workforce that works on getting this data. Others have a full team of people that spends 10 to 15 hours a week acquiring data. So it's very expensive in that way too, that, payers are seeing the consequences of missing measures, but also trying to spend money making things work. And I think NCQA actually said, like, it's the impact of like this missing messy clinical data could be in like the tens of billions of dollars into our healthcare system as a whole. So it's definitely an expensive problem. Definitely excited to see improvements.
Great. I think let's get a little bit more into the details of that. When you've had a lot of conversations across the board, really specifically with the quality and the HEDIS teams today, what does that current state actually feel like when you're within the organization? The chart chasing, the data lag, all those sideload systems.
Yeah. So there's a number of challenges that were consistent across the board when we talk to payers. One of them is just, I mean, data is everywhere. There's many provider organizations, different types of provider organizations that structure data differently. And it's really hard to make sure you're acquiring all the data from all these different providers. I'd say the biggest concern with payers too is the provider burden. So they're really concerned about, providers being burnt out from this back and forth as they try to acquire the data. They don't want to push it, I guess, with providers. They want to make sure providers have a good experience, and that's been really hard. It's a hard tension point, and everyone just wants the data to be flowing better, and it's very time consuming for everyone involved, which is not ideal. And then, I think, like, even for organizations that have some connectivity with certain systems, even for like the outstanding data where there's not connected EHR data, the manual chart chasing is really a significant burden. And as I mentioned earlier, like, it's leading to a lot of like significant financial impacts, even for something so minor as like missing date inputs. So there's a lot of focus on trying to acquire data from a lot of different sources, which is really hard. And then also trying to make sure that provider relationship stays strong is really challenging as well.
Can you take us through a really concrete example of this that you've heard? Take a single measure and show how it went, how it runs today versus how it would run with DQM.
Yeah, for sure. So we can talk through like the breast cancer screening measure. In current state, a woman would typically have to go to like an imaging center to get a mammogram for that measure. That is separate from like a PCP, so it's a different provider organization. Typically what would have to happen is like after 60 to 90 days, the claim is processed. There's some sort of manual reconciliation that happens. In a perfect world, come October, they see like, oh, yep, this member who qualifies for a measure got their mammogram, fantastic. But there's a lot of places where that could not work effectively. So for whatever reason, there could be like an extended delay in the claim. There could be a lack of like a manual reconciliation happening. There could be a date missing. There could be a CPT code missing. There's a whole variety of things that can go wrong in that process. And so what happens often in current state is, you hit October and realize this person who should have gotten a mammogram doesn't seem like they did. And so that's when the chart chase happens, trying to acquire the data to prove that this person did have the exam that you hope they did. And so that's kind of a whole big process. And then that also has like an exclusion with it, that measure, which is like a bilateral mastectomy. So a challenge with that is often like, a woman could have had that 5 years ago or 10 years ago, and before that person was even a member. And so oftentimes that could lead to like false positives in your denominator, just contributing towards like a potential missed HEDIS measure. So, a lot of things can happen, I think, just with current state. And with DQMs, what's really great is, it's continuing the momentum towards like FHIR interoperability. So you'll be able to acquire FHIR data from provider organizations more seamlessly, so that you can pull in the FHIR data. All of that data can get married together, the clinical data from a variety of sources, as well as the claims data. And you'll start to have this longitudinal record based on FHIR, where you can, without having to do that like extra chart chasing, you can just look at the record and actually see the data and follow up much earlier in the year if you do see anything missing, like a date, or if you see that a member actually didn't get the care that they needed. Another thing that I think is particularly exciting is the convergence of this with CMS 0057 P2P APIs, where you can actually get data from a member's previous payer. And so for something like a bilateral mastectomy that happened 5-10 years ago with a previous payer, you can now start to get that FHIR data as well, and that can be weaved into that longitudinal patient record. So you can just be armed with way more data, which should reduce the manual chart chase, but also just give you a lot higher confidence in the data that you have.
Makes sense. Mohammed, I'm going to switch to you here for a little bit. Before we get to actual solution, what makes pulling clinical data for measures just so hard today? This seems to be a challenge, as everything Elisa has alluded today. As we know, data spread across multiple source systems in different formats. What does that actually look like when you're on the ground?
Yeah, so hey everyone, thanks so much for joining. So what's interesting about this shift to DQMs is it changes the problems from the manual laborious process of getting the data to a technology problem. And I think that's where we start need to understand what technology challenges need to be solved to get this done. And just bare bones simplifying it, for DQMs to run, you need a couple of things. One is you need data in one place, all of the data that you need in one place. And then you need a layer called the CQL, which is the clinical quality language data, which defines each measure, how you measure it. For example, if you have a colonoscopy that has to happen on date X for a certain member, it's able to look at the entire record of that person and say, okay, this happened or not. Now, the challenge with this is, first, to be able to get all of that data into one place. All of you are familiar with the information systems at the plan and how fragmented they are and how it's across the board. Even within the four walls of a plan, usually you have your care management system, your UM system, your CAPS, your multiple vendor or delegated vendor systems that you're using, that your member data is spread across, your pharmacy and benefits, all of them contain that data. Those systems don't talk to each other. So that's your first challenge, is internal, where how do you get all of this data from those systems into one place? The second problem is external. That data for your members is spread out across HIEs, EMRs, and multiple types of EMRs. and in multiple locations. So then the challenge is not just internal, but also externally. How do you get that data and put it inside of your four walls? That's the first big challenge. Now, when you get that data, the data is in multiple formats, not the same format. If you're getting data, let's say you have a payer-to-payer integration, you got the data from a previous payer for a plan, you're getting that data as FHIR data. From an EMR, it's FHIR data. From let's say an HIE, it could be CCDAs, it could be you're getting it through flat files. Someone has to consolidate that data so that it's one uniform shape, so that it can be queried using the CQL language. And that's hard. And the extra layer of complexity that prevents this is, even if you're getting data in FHIR, FHIR determines the resources, how they should be communicated. But where data actually sits inside those FHIR resources can change from vendor to vendor. You can get data from one plan and they decide to put their lab results in a certain location. Another could put it in a different location in a different format. That creates a ton of messiness in data. And that has a direct impact on the quality of the measures that you're going to generate, because that cleansing has to happen upfront for it to work really, really well. And that's a big technical problem that has to be solved for this to work. The other part of this is also the ownership problem, is who owns doing this and who owns managing and monitoring it. So there has to be someone knowledgeable with data transformation who has built infrastructure in your organization that monitors any gaps and challenges there. If a pipeline breaks and all of a sudden you're no longer getting data from a certain EMR, that's a silent break. You're missing some data that's temporally needed to be able to close a gap, but now you don't have it. And we've had at least one plan we've talked to who said that has a multi-million-dollar impact when these things break silently and no one owns it and is tracking it.
Makes a lot of sense. We talked a lot about the EHR, and we know that those EHRs have those standardized APIs, and they're transforming that access to the EHR data, regardless of which EHR you're accessing, a provider, hospital, or health system across the board. But some providers actually have multiple EHRs. They're operating in systems that have merged and consolidated. That's a real challenge. Can you talk about that as well?
Yeah, so here's the positive and the negative. First, the positive is, thanks to HTI regulation, EMRs have to expose APIs that allows you to extract data out with consent, obviously, out of those systems in FHIR format. That's perfect, because that gives you a way to access it. Now, the challenges with this is that data right now is on V3, USCDI V3 format. And it's comprehensive, but not exhaustive. So not all of the data exists there. That's the first challenge. The second challenge is, even within an EMR or a provider, they might be using multiple EMRs to get that data. They might have FHIR for some of their outpatient use cases. They might use Epic for their inpatient services. Those two have different connectivity, different challenges. You still have to connect to both of them. You still have to consolidate into one place. Sorry. So the challenge then is getting those connectivity. The third challenge is, even from site to site, there's variability in what data you can access. So let's say you have an Epic instance across 3 providers you're working with. It doesn't mean you're going to get the same data from those sites, across those sites, because some of them might configure, for example, certain limitations on behavioral health data, where they need to go through certain hoops to get that data. Others might limit other areas, and that's within their control, because that depends on their policy for data sharing. So that also creates variance in the type of data you can expose out of those systems.
So even once you have this data, you've done it, Mohammed, you've done all the technical work required to access the information in the separate EHRs within a health system. You alluded to this, but once you get that data, quality is really a separate problem. We've got the data, now what do we do with it? What kinds of data quality issues do you see that can break measure generation if they're not caught early?
So that's an awesome question, but also it's complicated, because this is where I would say differentiate some of the small to medium health plans from the large plans, where this is a big problem that requires a ton of expertise to figure out. Because data quality, there is no abstract measure of data quality for data. It's always relative to the use case being used. So I'll give you an example for that. Let's say you're getting content of sediments inside of a urine test or a sample. you can report on that in multiple measures. It could be milligrams per mole, it could be milliliters per micrograms. There's multiple ways to measure it. You have to standardize on one and make sure you're doing it across the board. Because when you feed it into your CQL, it's expecting either an indication of what the measure is and consistency when you're doing that. That could throw away completely your lab result if you don't have that measure. But that is in the context for your, let's say, NCQA. And NCQA is doing a good job where they're now working on the quality. They're working closely, and you can check their website for some of the work they're doing. They're working on publishing some of the quality assessments needed so that when you get source data, they tell you this is the way you can validate that this data conforms to that CQL, which is phenomenal. But then that has to be codified into the data pipeline you're fetching the data from, one. Two, it has to be as upstream as possible to the source data. Because let's say you have these three EMRs connected, you have these gates around data quality set up so that when you're funneling the data, now you need to flag when the data deviates when that's needed, and then you need a way to push back into that site to say, hey, we're expecting you to send us in this format. You sent it this. This is breaking our pipeline. Please fix it. And you have to do this in timely manner. Otherwise, you're going to see drift in your quality measures. That's not because of you. It's just because of the connectivity and the data problem that's happening there. And I say we when we talk to one of our customers, one thing, or one of the payers, they mentioned, for example, like date, which is as simple of a concept, but is one of the most complicated things in data, because dates can cross time zones, they can cross formats, and sending the wrong format means you're generating a wrong date. And when you look at things like, okay, if a baby was born on a certain date, there's certain things that have to happen starting from that date within the 30-day period. What happens now is you have to go and chase down what happened and you have to reconstruct the timeline of what happened. Sometimes that's manual, sometimes that's from systems with different time zones and areas. And that can introduce tons of errors. In one case, we saw something like $7 million worth of problems attributed to misalignment of timelines that happened for certain records for the plan. So that puts more pressure on, one, timelines, and two, making sure that your system is understanding these nuances and capturing them.
Makes sense.
Just to add on to that, I think for like the missed dates and the big like $7 million impact, I think the way the payer described it was like there were so many formats of dates and like there's so many ways to do it that when they kind of retroed with the folks who are abstracting the data, they were too nervous to input a date. Like they didn't want to do it wrong. And so literally no date was entered because they were like, I don't know if I'm doing this right. So it's causing a lot of stress and obviously has the financial impact too.
Yeah, that you wouldn't realize at that moment in time. You're just worried about being accurate.
Yeah, and maybe just to add to that, like Elisa, that's an excellent point. And the funny thing is, this is a solved technology problem. There's a lot of things in the world that uses data to drive a lot of like financial transactions, liabilities, all of that. That is a solved problem, but that's a technology problem that has to be considered in the data pipeline so that this prevents these types of challenges.
Makes sense. MJ, I'm going to pop this to you, but Elisa might be able to weigh in here. We hear a lot about primary source verification. This has been the industry standard, and it comes up consistently with auditors. Why is it such a sticking point, and why is it so hard to do that at scale today? I have not had a conversation in my 10, 15 years in the industry that hasn't focused on this. Yeah, go ahead, MJ. Yep.
I'll start. Elisa, please add anything. So all of you who've been involved in quality measures for a while know how much PSV is core to the auditors when they're going through that. And just for context, this is where a human or a person actually screenshots and validates that this data was captured correctly from the source system. This is highly reliable because obviously you have a human attesting to this. The problem is it's not scalable, because you can't have humans go through, when you switch to full population, you can't have armies of people go validate this from source system. So for the shift to DQMs to happen, primary source verification should be modified in ways where the pipelines are attested to or are confirmed, where someone in NCQA or someone says like these pipelines support this. And I believe there's on NCQA's website, one of the things they said that's coming up in 2027 is more support for that pipeline validation. So what that does, now the industry is moving towards that. Now, we're not there yet 100%. That's why there's a staggered measure shift where some of these measures are being shifted to electronic. But the idea behind this is when you remove the human in the loop, now you put the verification in the pipeline, and you need to make sure that the pipeline itself is set up in a way where there's validation, there's provenance supported in it, and there's some sort of guarantees that this data wasn't manipulated and changed throughout its entire life cycle. That's data governance one-on-one. That's how you build trust in these pipelines. And when you talk to NCQA, you're going to have to prove to them, like, hey, I can guarantee that when I fetch the data, nothing changed it in transport, whether maliciously or non-maliciously. It's like, look, I can attest that the way I got it is this. This replaces PSV. We're not there yet, but these technology are being put in place. And I know NCQA, from their messaging and everything, they are working towards eliminating more and more.
Makes sense. I think there's this fundamental piece that gets confusing in the industry. One of the longstanding challenges with clinical data has been the format. USCDI versus FHIR. How does FHIR work here? And what is the difference between the standard and the pipe? Can you help this audience understand that? I think that gets really confusing when we start to think about the fundamentals. And I think sometimes we potentially use them interchangeably. It'd be good to get into the details as best as we can here.
Yeah, so if think about USCDI as these are the data content that need to be shared whenever you're talking to someone and saying, I'm sharing with you USCDI v3 data format. Like, these are the resources, the entities. For example, it has patients, it has labs, it has immunization. Like, so when someone says, I can give you the USCDI v3, they're telling you I can give you these elements. FHIR is the way you're conveying that information. So it's basically how, like immunization, this is how it's structured when you're seeing it. These are how the data is going to be laid out. So that's the difference. And you can think about the FHIR as the way we're telling you the data, and USCDI almost the content of that data and what it contains. And you're going to see USCDI continuously improve and expand over time, which is why you're going to see over, like, as ONC reviews the versions of CDI, they're also incorporating all of the measures needed. Like, they're working with NCQA and say, okay, if these things are a must for quality measures, let's put them inside USCDI. And that's why you go from V3 to V4 and more, which means, like, now FHIR doesn't change per se. You're still using the same language, but the content of what you're sending there is going to evolve as USCDI changes.
Makes sense. So let's help the audience here understand, how does OneUp actually break down these silos? Walk us through how data from all these three different sources comes through and becomes a single patient golden record, that longitudinal patient record, the exciting thing we keep talking about in the console. Lisa, I think you're really positioned to help us understand this. Can you help us understand how that actually comes to fruition?
Yeah. So OneUp is and has always been a FHIR native platform. We speak FHIR, we transform claims data into FHIR. We have a variety of converters to get different formats into FHIR. We can connect directly with EHRs and pull in FHIR data from these mandated endpoints. So we're able to pull all of this in, and because FHIR is this language of interoperability, we can marry all that data together pretty well and create this longitudinal patient record then that is built off of a variety of these sources, some of which, come from the direct FHIR endpoints, and some of them go through, some of our converters. And so that's really how we do it, bringing together a variety of these sources, including, as I alluded to earlier, that previous payer FHIR data as well from the CMS 0057 P2P API. So we're kind of the consolidator there that creates this great golden record that you can leverage for these measures.
And Elisa, I would add here that, like, at OneUp, we found ourselves in an opportunity to help this, because what we discovered is, and for folks on the line who probably haven't worked with us from a compliance angle, like, as a vendor who wants to ensure compliance for our customers, the number one thing we're good at is we go into those systems and that you have, and then pull the data and then centralize it. Because when we share data out to another payer, to a patient, to another provider, we have to share by regulation all of the data we know about this person. So when we looked at it, I'm like, wait a second, like, this has all of the data needed to be able to run these CQL measures. And the hard work has been done to standardize and put it in one place in here. So we're like, we are well equipped to support this because we already tackled some of the first. Now we still have a lot of things around that we need to support it, but it's just a natural extension. And I would say part of NCQA's move is to allow folks like us who are FHIR vendors who have been doing this to basically make it easy, because now they're saying you're holding into the language, you have all the data, run the CQL on top of the data, and then you can already benefit from the interop that's happening. And that's also what ONC is trying to do. Is like they're saying, and CMS, they're saying, like, look, if an interop vendor or you are building a server that has all of this data, you should be able to use it to be able to do your quality measure in a central place and not fragment across the ecosystem.
Yeah. Good. I think one of the things, Lisa, we spend a lot of time in the space with our partners, and this relationship between the provider and the payer is really critical. What have you seen work in terms of best practices here with providers for clinical data acquisition and really just overall success within these partnerships?
Yeah, I can start off. So there's a number of things that help. I think like number one, great open lines of communication. Payers that we've worked with as we acquire clinical data, like setting up time with providers, understanding their pain points, what's important to them, is like foundational. Yeah, having the open dialogue is really critical. I think also providers really want to understand, like, what is the data going out? Am I confident I'm not sharing data that I shouldn't be sharing? What measures am I sharing the data for? All of that's really important for providers to understand, because they are kind of guardians of very sensitive data, right? And then it's also really important for providers to get transparency into not just the data going out, but they want to get something in return too. They, in an ideal world, would see the claims data coming back to them. That's another thing that is becoming more available with the provider access API as part of 0057 as well. But I think having that open dialogue with providers of like, what do you feel that you need, is a great step in the right direction. And then kind of the last thing is, it's just so it's so clear that everyone feels a big burden of clinical data sharing, right? So I think a big thing for us as we've been connecting with providers is ensuring that the burden on them is minimal, right? We want to make sure that it's really easy for them to just set up this connection so that payers can acquire the data they need, and that providers can feel really comfortable in the process. Mohammed, is there anything I missed that you'd want to add?
I would say you've nailed it. I think that just making sure that also the payers can show ROI for the providers. That's the key thing, is showing that somehow either a scorecard or something to gain their trust. Because if they think they're sharing data and there's not value or they're not seeing the impact of that, they're going to shut down the pipes. And we've seen that multiple times where providers say, I'm sending you all of this. I have teams, armies of teams who are supporting this, but you're not giving me something back.
This really is an area that we've been leaning into to provide solutions for. Can you share an example of a health plan or two that's actually gained value from capturing full population clinical data?
Yeah. One of our customers who's been using our Clinical Connect offering, we help them acquire data for a roster of about 85,000 members. And we're able to, pretty easily acquire like millions of observations and counter data. I think the most like notable stat that we saw was on average, each member had over 350 clinical records, which is huge and has a big impact on quality measurement. I think data has shown that claims data alone for a measurement will be like 15 to 25% lower than when you infuse it with clinical data. So you see a huge positive impact with those quality measures, and the chart chase is just reduced as well. You're getting all this data. The setup is very streamlined. You're acquiring this data on a frequent basis. And yeah, you don't have to do that back and forth. as much. So the burden is a lot lower on both parties, on the payer and the provider side, which has been really exciting to see.
MJ, how close to real time can you actually get to this data? And why does that timing matter so much for quality care and care, closing gaps in care?
Yeah, that's an awesome question, because one of the things that you can get with this type of technical infrastructure is you can get as close to real time as possible. And what that means is, if you have a feed going into EMRs, if you have feed going into your care management system, and you're pulling that data, it doesn't have to be on an hourly basis. It would probably be too aggressive. Maybe let's say every 24 hours, putting that data and refreshing the roster of data. That means at every 24 hours, you have a full view of your patient at all time, what's happening with them, what they're doing next, and the next best action for them. That's where you can start impacting their behavior and helping close gaps. So you can imagine, for example, an ADT feed coming in, you notice something there like an admission, an ER admission, you get that view, immediately that triggers into your care management and outreach for that person. If let's say they have a multi-morbid condition, and that care management can then reach out and say like, hey, notice this is happening. How can we support you? What we can do? So you can quickly close some of that gaps and what's happening there. The challenge, if you don't have it this way, you're relying on the old batch ways of getting data, which sometimes is monthly, sometimes every 90 days. At that point, you're past the point of actually influencing the behavior of the member. And this is where it's not just the real-timeliness of the data, but it's also how you're pushing it into systems of engagement or your member engagement platform, their portal, your centralized analytics or next best action engines that you have. So that's why the faster you can get the data, the quicker you can impact their behavior positively in the dimensions you care about.
Also, I think I heard you as we've kind of gone along in this conversation, you mentioned validation is baked into the ingestion pipeline rather than kind of bolted on at the end. What does that really mean in practice? We can talk about a lot of things, but how do you actually think about this? And really, how does this matter in the NCQA data quality work?
So the idea here is, so we talked about having these feeds coming in from multiple sources. You have an HIE feed, you have a feed coming from EMRs. What you can do is, the moment the data lands in your system, your data pipeline has to run all of the data validation measures based on what NCQA tells you are the good data quality. Again, this is on their website. They're mentioning all of the work they're doing. All of that work can be baked into these pipelines. Once you have them, now you pair that with some type of reporting and alerting mechanism of these alerts, and then it becomes on the end. But this effectively means you put those as gates in the data pipeline, so on ingestion, which means after that point, you have high degree of confidence that the data now looks the right way, and you can run your analytics on it continuously with low rate. Now, no one's going to get this right from the first time. You're always going to have things where your team discovers challenges in the pipeline or data quality. But by putting it there, you can actually continuously improve the data quality for your organization by adding it there more and more and expand. So that becomes almost like the defensive mechanism for your data in that pipeline. And the beauty of this is this is something you build once, and you will use it all of your life for that pipeline, because that effectively becomes your way of guaranteeing the data quality stuff, instead of having someone go into an EMR, check a file, and then every time they have to validate it's the right value, it's the right format, and the right quantity set up. That's done just once on upstream.
Lisa, I know you're thinking so much about all of our DQMs and HEDIS measures, and all this really becomes critical when it comes to these measures. How does that, we talked about that longitudinal record, we've spent a lot of time thinking about that and what that visualizes like, but how does that longitudinal record, clinical and claims record, improve the numerator capture, which is critical in doing the measurement around this, and the exclusion accuracy and the care gap identification? How do you think about that?
Yeah, I think, I mean, in short, it's just the more data you have, the more accurate your data, the better your HEDIS measures are going to be. So from a numerator standpoint, like we can go back to the BCS measure of when you're acquiring this FHIR data from a multitude of sources, you're able to see if, you know, a member got her mammogram, and you can also be more confident if it doesn't show that member did, that's like an accurate result, right? And similarly, from an exclusion standpoint, if you're I mean, you can actually see data from a variety of provider organizations, but also like the history from previous payers as well. So you can actually have a lot more confidence in the members who have exclusions and feel more at ease at not having those false positives in your denominators. And then, from a care gap and member engagement standpoint, you can feel a lot more confident just in the communications you have. I think like the last thing you'd want to do is badger a member about a mammogram who's had a bilateral mastectomy, right? Like they don't want to hear that. So you'll just feel a lot more confidence the more data you have, the more structured, the cleaner it is in, the measurements, but also in your outreach to members and ensuring they're getting the best care possible.
Makes sense. MJ, done an amazing job. Data's clean, it's audited, we have it all right. Elise is doing the work with the payers on the measures. Where else can we actually put this data to work? It doesn't just have, we've spoken a lot about HEDIS, but what else can we do this? How can we think about more advanced analytics, how we work with other vendors? I think these are like those exciting use cases that come beyond just HEDIS.
Yeah, and that's the awesome part, which honestly, this is what both CMS, ONC, and everyone's trying to push towards is there's a ton of data fragmentation. But the moment you put it in one place and you put rigor on top of it, now you can do a lot, especially if you're a small to medium plan. Because if you're a national, you probably have invested armies of engineers in consolidating that data in one source of truth to be able to drive your business. But this is a chance for small to medium plans to do the same thing, driven by this. So once you have that data in one place, if you look at it, you're going to have a golden record for the patient that says this patient, this is everything tied to them. You have all their conditions. You have what's happening currently with them, what potentially schedule prescription drugs they're on, and also who they see from a provider perspective, and what kind of encounters or upcoming encounters they have with the healthcare system. When you do that, you can start, instead of pushing actions and activities into other systems. So you can imagine pushing things to the care management platform for supporting people. You can start imagining tailoring marketing and targeted towards them to support them with what they need. Let's say, a new mom, they're expecting, you can target them with a care management platform, target for prenatal, and supporting them with that and teaching them like what they need to do. And you can create a lot of member engagement, but also you can figure out and run analytics and AI on top of these with vendors outside of OneUp, where you can say, you know what, there's a new innovation where there's company that's coming up with a new way to do risk scoring for your population. You have the data now in one place. You can just literally turn that data on for that vendor, and you can experiment and have that vendor run. And the reason why this is important is there's a ton of innovation that happens in our ecosystem. The problem that a lot of analytics and new AI innovation fail is because the teams that are super smart at building these models don't have access to clean and good data to be able to do it. So once you give them that data, you can imagine how much innovation would shoot up, and that is a return on investment for the organization. So there's a lot to do here. There's a lot of ways, but having this data in a clean place just unlocks so much for the payer.
Okay, I'm going to hop us back to NCQA because that seems to be our favorite topic at times. Elisa, when a vendor has NCQA accreditation, what does that actually unlock for a plan that wants to generate quality measures?
Yeah, so there's a couple different things. There's measure certification, which is what like a vendor needs to have if they want to calculate the measures. And essentially it just ensures that that vendor is a legitimate organization that NCQA has confirmed is like well suited to calculate the measures. Also, the vendor then has the burden of the compliance, right? So it takes a little bit off of the health plan's plate. There's also health plan accreditation, which is required for many plans, depending on the state and the lines of business, which essentially just helps plans have the proper documentation and controls framework in place to ensure all of this goes smoothly. And much of that is documented on the NCQA website too. yeah, but it's all there to ensure that health plans are supported and there's consistency and controls in place to ensure there's not something that's going off the rails.
All right, MJ, back to you. We're gonna go back into your frame. We've got a lot of technical folks in the audience, and they really are thinking like, that sounds great. We love the NCQA, we love the other vendors and all the work that you can do, but how do you actually do this? What is the infrastructure that you actually need to make this happen at its foundation? What can you share here?
Yeah, so maybe just thinking of this abstract of what you can offer. If you are currently an organization and you want to do this, the first thing you need is you need a way to pull data out of all of those disparate systems. When you pull that data, you need a way to take unstructured data, for example, PDFs, images, whatnot, extract data from it and enrich the data you have. Then you need a layer of quality control over that in your data pipeline that goes over all of the important measures, checks them and validates them. 4 is that data, when it lands, has to be merged with your existing data to create a golden record. So this is what you need here, what we call an entity resolution, which effectively, when you have 2 patients, an entity resolution layer tells you whether these 2 patients are the same or not, because you might get one data from a payer to payer, another you get it from an EMR. You have to be able to match these and say, is this the same person, with a degree of confidence, because if you're not, you're exposing HIPAA data if you're merging incorrectly. So now you have that data, you run it. Now you need to put it inside of a data store that is scalable. Here you're talking about terabytes, if not sometimes petabytes of data based on how much information you have. So that data should be queryable in a time-efficient way, in a performant way, because CQL, when you run it on top of this, has to be performant. You can't run it for days and weeks to be able to generate some of these measures. Once you have that done, the next step is going to be an important alerting mechanism for any deviations and any problems, and connectivity into any system where you want to drive engagement. And lastly, you want a reporting layer on top of that, which is something that your team is able to look at, measure. And one important thing, and I'll actually touch on a question that's at the same time that's in the Q&A, which is, if you go to ECDS, won't you see star ratings drop? That is probably could happen, but the reason why is because right now all of the measures are being done retroactively on the data you have. When you start measuring CQL continuously, running the data, you're able to surface these things and gaps in real time, so you can go and plug them. So when you do that, you actually gain more control over your ECDS measure and what it can accomplish because of this pipeline. And that's why it's important to have that real-time component of, hey, there's a problem here, let's go fix it, because that's going to hit us our star rating when we have to report back in X period of time. So that's in a simple way, those are the pipelines. There's a lot of nuances in them, but these are the core requirements needed.
Makes a lot of sense. I'm going to start to close this up, and I'd love to we have some questions in the chat too. If we can start to incorporate some of those questions, it would be super helpful. Beyond the quality department, how does this really reshape an organization, reshape network design, prior authorization, care management, all of the conversations, member engagement overall? Can you share some core examples around what this looks like? And I'm going to pop that to both of you.
Yeah, I can start, and then I'd love to hear Mohammed's take as well. I mean, it feels like the sky's the limit when you have really good comprehensive data on all your members. It's like it can touch any part of your organization. From a care management perspective, when you have a full, clear picture of your members, there's so much you can do. And when you have that clear picture, like throughout the year, you can take action quickly and actually have like an impact on your member outcomes, which is really exciting. From like a network design perspective, you can start to look at the data you're getting from different providers, get really interesting insights from each of those. I'm trying to think like from a prior auth perspective, again, it's just like the more data you have, the more informed you can be with your decisions, the more analytics you can build, et cetera. So I just think like, frankly, sky's the limit with the data. It's obviously super impactful for quality measurement, but there's really like so much more you can do with comprehensive member data.
Yeah, and I would say probably the best way to approach this is, as an organization, when you look at ECDS and the infrastructure needed there, don't look at it as, hey, I'm just going to tackle my NCQA must do for the next year. Use it as an opportunity to say, like, look, I have these business challenges in my member engagement, in my population health challenges, in closing gap, all of that, and use this as the springboard to go and fix this. Because for the first time ever, you probably have your data in one place where you can drive this with high quality. You can do a lot with it. And I think we're going to see a lot of new use cases pop up that were hard before that are easier because of this. So net, this is positive, albeit it's a bit painful to get there.
Great. Thank you, guys. Okay, if I'm sitting in the audience, I'm thinking, how do I actually make this actionable? Like, what are the next steps here? Seems like a lot. We're thinking about 2030. We're thinking about the now on compliance. How do we start to put this in place? What are some practical short-term steps for moving retrospective chart abstraction to continuous traceable quality measurements powered by interoperable clinical data?
I think there's a number of steps you can take. I think the most important thing is first, like, look at your data, look at like the last couple measurement years, like where are there issues, what's causing those issues. I think then you'll start to get an idea of certain areas where you can focus as a starting point, because trying to boil the ocean and get all of your data from everywhere all at once is probably not the most effective way to go about things. But first, like, understand your data, figure out a good place to start. I'd also say, like, figure out, if there's a provider group that you work really well with, like, start there, figure out how you can start pulling in that data more effectively. Figure out like how you can enhance that provider relationship, all those types of things. I think, like, I might even hand it off to Mohammed too. Like, you talked about like the quality checks, like make sure those are in place, right? That's probably something you want to figure out right from the get-go.
Yeah, and here's the thing. This can look daunting if you look at it, but you have to remember that NCQA is doing this in stages. So, which means payers who think proactively about this will be able to approach it step by step. And what the way that looks, to Elisa's point, is pick a measure that's going to be converted, run it in your organization, see the gaps, and then see, how can I run ECDS for this end to end? What do I need to do? And then start iterating on that and go over and over to see what gaps in your organization you have. We have one of our customers who we've been working with, and I think this is the use case that Elisa mentioned, is doing this proactively, knowing that they have good relationship with some of the providers. They're like, can we start showing proof of concept with those providers to show them what we can do, and then plug some of these gaps now, because then every year we're going to be, our infrastructure is going to be ready to get close to that. That is the right approach. Regardless of how you do it, which vendor you use, the best thing is to approach it incrementally that way. Otherwise, doing it a big bang is going to be too disruptive to the organization. And plus, you can spread out the budget over the next couple of years of taking one and doing it and picking the vendors you want to work with, what to do, versus saying, okay, I'm 1 year out, I need to do this, and then it becomes disruptive to the organization.
Makes sense. Okay, guys, I think we've gotten through most of my questions today. I'm going to hop over to, we have some questions in the Q&A that I want to address. This question comes up a lot. Why not just use TEFCA or a QHIN for this data, or QHIO in California? Why do you need this actual connection to the EHR?
Yeah, I think of TEFCA or QHINs as like one of the pipes that funnels in data, right? You're not going to get all the data that you need, but is one of the many sources. And like at the very beginning, talked about like slight differentiation between DQMs and ECQMs. Like ECQMs are that focus on EHR data. Like DQMs are intended to pull from a variety of sources, and I see like a QHIN as one of the pipes that feeds in data.
It's a complex problem at the end of the day, right? There is not a one and done solution. I'm going to kind of combine here two questions here. Want to think about, we talked about the longitudinal golden record, however we want to say that. How do you actually match patients across all of these sources, and let's talk about how we approach it. I think that's what we know best. So I think that'd be a great way to sort of wrap up and end this conversation today. And I'd love for you both to take this question.
Yeah, I'll start from a technical perspective. This is something we're doing now with our customers who we're onboarding into the platform. So part of our data ingestion practice is we do pull data from your PBM, from your PBM, from your claims management system, and your UM system, and care management system. Each one of those has different demographic information for the same patient. with different slices. So the way we do it now is we have this, what we call the entity resolution layer, that helps you figure out who the patient is and generates a score of how likely are these two entities together. And we only merge these records when we have high degree of confidence. If we have any doubt about those two members being the same person or not, that's where we have a human in the loop to go interfere and plug that gap. So that's how we do it now. It's a combination of basically AI in a probabilistic and non-probabilistic way that basically gets to the highest degree with a human in the loop. Now but we don't just use it for combining. We're also combining duplicate information. If you're getting a claims from one place and a claim from your clearinghouse through your X12, we actually can match them to see if this is the same claim or not, and then combine them together and mash the data together to create a single record of claim mapped to that patient. Lisa, anything you would add?
I think that covers it really well. Just from maybe a tactical standpoint, when we do work with customers who are ready to acquire data from a provider group, part of our implementation is we figure out the best way to match that data. And it's different. For different payer provider relationships, it may be leveraging FHIR IDs, it may be a combination of maybe an ID plus certain demographic information. So that's part of the conversation we have when we're setting this stuff up to ensure it's going to lead to the accurate results, right? But also a result that will, be manageable lift on both ends.
Makes sense. I think we've covered anything that we've missed today, or any items that you'd want to wrap up here. I can't think of any personally, but just want to make sure that we've hit all the items.
I think there's one question around how OneUp is approaching this. I would say right now our focus is on all of the data infrastructure needed to support this and run it. What will this replace your HEDIS engine or not? I think this is a customer by customer conversation to see which vendor they're using, because we have some partners in place. Sometimes if they don't have, there's some places where we can generate. So we can talk closely to understand your use case and lean into that.
Yeah, definitely. We're always here to have those conversations. I think we're all figuring this out together at the end of the day. As I say to probably every single customer, they get tired of hearing it. Every system looks different. Every prior auth solution looks different. These HEDIS solutions are all going to look unique. And we talked about QHIN and TEPCA and connecting directly to the EHR. It's going to look different dependent on your population and what you're trying to achieve and what the goals of your organization are. So it's going to take a hand-stacked team effort. Well, I want to thank you both today. The conversation was so much fun. It's just a great topic to have, and we're so excited about the future. Thank you for the audience who participated today. We appreciate your time. We know that everybody is very busy. Again, remember that this webinar was recorded. You can share it within your organization. You can view it. You can go to the critical pieces, and you can reach out to all of us. We're happy to have a follow-up conversation. As you can tell, we love to have this conversation. We love to think about the future. So we're thrilled that you're all here participating with us. Have a great day, everyone.
Thanks, everyone, for your time. Bye.
Thank you so much.